I'm sure more will join.
Yeah. It's all right. Yeah.
Good evening, everybody. Today we are going to have the next lecture on the college lecture series. As you know, today the lecturer is going to be Professor Kuruppuarachchi from the University of Kelaniya. I know that he doesn't need any introduction to the audience, but anyway, as the tradition, as the customary tradition that we always start with, I'll do a very brief introduction of Professor Kuruppuarachchi. Professor Kuruppuarachchi passed both the MD Medicine and MD Psychiatry at the same time, the same year. And then he opted to do psychiatry because of the interest in this field. And we are very lucky that he decided to do psychiatry and not medicine. And then he went for his overseas training at the Newcastle Rotational Training Scheme in the UK and returned to Sri Lanka in the year 1992. And I think, sir, you started with Kandy General Hospital, if I'm not mistaken.
That's
yeah.
Right. Yes.
And then after working for a few years at the Kandy Hospital, you proceeded to the University of Kelaniya, and you were the founder head and the founder professor of the Department of Psychiatry of the Faculty of Medicine, University of Kelaniya. And Professor Kuruppuarachchi holds the two fellowships, fellowship of the Royal College of Psychiatrists in the UK and the fellowship of the College of Psychiatrists in Sri Lanka. And he is currently the senior professor of psychiatry at the University of Kelaniya and the K.A.L.A chair of psychiatry of the same university. Professor Kuruppuarachchi has contributed to a lot of textbooks, as well as he has done many national and international publications, and he has been awarded several prestigious awards, national and international, at the national and international level. And he has been awarded the President's Research Awards and the prestigious Kenneth Rawnsley Traveling Fellowship awarded by the Royal College of Psychiatrists UK for the year 2000. And as we all know, Professor Kuruppuarachchi has been an examiner of the Part 1 as well as the Part 2 MD Psychiatry exam for a long period of time. And he has been an active member of the Board of Study in Psychiatry at the Postgraduate Institute of Medicine for a very long time. And we are very lucky to have Professor Kuruppuarachchi today as the lecturer, because he's a specialist on neuropsychiatry, and this is the favored and the favorite field of expertise also. And thank you very much, sir, for agreeing to my suggestion to talk to the audience, not only trainees but the practicing psychiatrists as well, about epilepsy and the psychiatric manifestations of epilepsy. And he's going to talk to you all today on what psychiatrists should know about epilepsy. And thank you very much, sir, for agreeing and doing this presentation for us on a Sunday evening. Over to you, sir.
All right. Thank you very much, Gihan, for inviting me to do the lecture, as well as for your kind introduction about myself. Now we'll start the real work about epilepsy, right? Epilepsy and related disorders. I think trainees should follow the slides, then it will be easier, because I try to explain them in a very simple manner to understand properly. So this is, I'll start the work now, right? Can you all see these things? The slides are clear and can see again?
Yes, sir, we can see, they are clear. Yeah,
right,
and,
okay.
and, and we can hear you well. Yes.
All right, so we'll start, right? We'll go ahead. All right. To start with, we'll talk about historical perspectives. And if you look at the Babylonians, they have recognized epilepsy long ago, about 2000 years ago. And in fact, there are stone scriptures writing about even intellectual psychosis. So it's interesting. And Ayurvedic practice, they use the term apasmara to denote to this condition. Apa is loss, smar means consciousness. So they will be scientific in that way. And look at the ancient Greeks. They felt this was a a sacred illness, and people with epilepsy, they are possessed by gods. And Greco-Romans, they felt, again, the same, lunatics. They used the term lunatics to describe epilepsy. And they felt they were possessed by gods, and mad people or maniacs were possessed by demons. Right? That was the initial thought about epilepsy by the ancient people. This is a picture of the god, and doing something for epileptic patients. And then Hippocrates, he is a bit scientific, and he felt the primary pathology is in the brain, right? And excess phlegm in the brain rushing into blood vessels causing seizures, right? That was his thing. And then Cullen and Morrell, subsequently they developed their hypothesis or concepts about epilepsy. Cullen felt Pinel and both this neurotic illness, and Morrell felt it was related to hereditary degeneration. Then Brown-Séquard and Hugh Glynn Jackson. Look at Hugh Glynn Jackson. He's another person, a great person with a beard. It's interesting. And he put forward vascular theories, both. And then Hugh Glynn Jackson again, he developed it further and felt nervous instability and chemical discharge in the brain, neurons, is causing epilepsy, right? Or sudden excessive discharge of gray matter is causing epilepsy. That was Hugh Glynn Jackson's idea, and it was well respected those days. And then Todd, that is another famous character, Todd's paralysis. Todd, right? He introduced this electrical theory of epilepsy. He was highly influenced by Michael Faraday. You know about Faraday. So that was the initial development of epilepsy. And then in Germany, a famous psychiatrist called Hans Berger, he discovered the EEG machine in 1929, and that was a major break for epilepsy. And then Lennox and Gibbons, from 1935 onwards, they discuss about this clinical neurophysiology. And since then, the epilepsy, the understanding and the management progressed rapidly. That was the initial history about the epilepsy. Epilepsy, now define the term epilepsy. What is a seizure? It's an intermittent, stereotyped disturbance of consciousness, behavior, emotions, motor function, or sensation that on clinical grounds is believed to result from cortical neuronal discharge. That is a comprehensive definition put forward by Chadwick in 1993. Still, we rely on this really. If you look at that, this is a more recent one, and you must know about this. And epilepsy, that's a seizure definition. And epilepsy, a condition in which seizures recur usually spontaneously, then it is called epilepsy. So one single seizure is not epilepsy for the moment, but I think you are going to learn it's more about that. Now, epilepsy again, two unprovoked seizures occurring within 6 months to 1 year period. That is the accepted thing so far. Two unprovoked seizures occurring within 6 months to 1 year period. And look at the probability of occurring another following a seizure over the next 2 years is about 30 to 40%. So one seizure, if somebody has one seizure, there is a probability of occurring another seizure up to 30 to 40% in the next 2 years. So it's a fairly high number, and which figure will increase to 65% when there is a reason, when there is underlying cause, and when there are EEG abnormalities, right? So the figure will be further increased. Now, this is a more recent thing. 2014, International League Against Epilepsy, they put forward this at least two unprovoked or reflex seizures occurring greater than in 24 hours apart. So not 1 year, 6 months. Now they are talking about 24 hours. So today and maybe day after tomorrow, whatever, two seizures or one unprovoked or reflex seizure, and the probability of further seizures similar to the general recurrence risk, that is about at least 6%. It is also regarded as epilepsy. It's interesting, right? After 2 unprovoked seizures occurring over the next 10 years also regarded as epilepsy, or when there is a diagnosis of an epilepsy syndrome. Now, what are the syndromes of epilepsy? There are exotic terms like West syndrome, right? Or else juvenile myoclonic epilepsy, juvenile or childhood absences. So those are syndromes. So if somebody has a syndrome, then again you can label as epilepsy. Now, look at I think I just put that also. Epilepsy is considered to be resolved for an individual or individuals who had an age-dependent epilepsy syndrome, like say West syndrome or whatever, but are now past the applicable age. Now they are not in that age group, then it is regarded as resolved. For instance, again, absences, childhood, say maybe in 16 years of age, there at that age, it is regarded as resolved if there are no seizures anymore. Or those who have remained seizure free for at least 10 years, right? For the last 10 years, with no seizure medicine for the last 5 years, which is also regarded as resolved. If somebody has no seizures for 10 years and we stop medication for 5 years, this is a new thing, very new thing. And but still we go for that really. Most of the people, they refer to this, the previous slide. This is a new thing, right? Now I think the trainee should understand the classification of epilepsy, right? Classification. This is again interesting. There is a commission called International League Against Epilepsy, right? It was born in 1909 or established in 1909. And in 1960s, which has developed rapidly. And 1981, they put forth this, we all are familiar with this partial or focal seizures, primary, generalized, and unclassified. What are the partial seizures? Simple partial, complex, or secondary generalized, right? And then 1985 and 89, further developments were there. Now, more recently, people felt this classification is not adequate. So one has to change that. So there were now I.L.A. is International League Against Epilepsy Commission. They proposed 5 axes. Ictal phenomenology should be there. Seizure type should be there. And syndrome, etiology, and impairment should be included. Now single seizure regarded as a symptom in the past, not as a illness. With the seizure could be a symptom rather than illness, unless we put everything together. So this is the proposed one. The people felt new terminology and concepts were needed and recommended. And then there was an advance in knowledge of epilepsy, particularly with regard to etiology over the last few decades, genetic, structural, and metabolic etiologies. And people, Berg, they proposed flexible multidimensional approach in 2011, right? And I think this is a very interesting and this is a very important picture for the trainees as well as for the people who are practicing psychiatry and neurology, put forward by International League Against Epilepsy in 2017. Now look at this picture. This is a multi-stage classification system. Seizure type should be there. That's the primary thing. With this focal, generalized, they inserted this unknown category also. And with that, the next stage is to find out whether it's a focal, the seizure type really, focal, again generalized, and put forward this combined generalized and focal, combined generalized and focal and unknown category. The next step is to find out the epilepsy syndrome, right? So 3 stages there. On the right hand side, you can see the etiology that is also inserted, structural, genetic, infectious, metabolic, immune, and unknown etiologies. You all are familiar with these things, isn't it? More recently, these immune mechanisms were highlighted. You know about the autoimmune encephalopathies like anti-NMDA receptor encephalitis and so on, anti-LG1I, so many things. And genetic, lot of genetic research has been done, lot of studies, and if you read, you come across so many things. Infectious, you are very familiar. Sometimes the etiology may be combined. Some people, they do have genetic as well as structural problems like tuberous sclerosis, for instance. Sometimes genetic and metabolic, like amino acid metabolism disorders, porphyrias. So there are etiologies highlighted, as well as the other side, you can see the comorbidities. Now psychiatric as well as neurological, or other comorbidities. Psychiatric, you know, the psychosis, mood disorders, social, even psychosocial problems were included there. And then autistic spectrum disorder, likewise, some neurological conditions, paralysis, like cerebral palsy. So comorbidities, so there, mental retardation, learning disabilities, lot of things. So this is a very comprehensive classification, very recently put forward, few years. This is the same for neonatal period. I put this because this again interesting for psychiatrists. With the neonatal period, you know, temporal lobe seizures are a result of febrile convulsions or hypoxia during neonatal period. So here, again, the seizure types are almost the same: focal, motor, and unmotor. And here the electrographic, like, there is another category, and then seizure types, epilepsy types, and syndromes. Etiology: hypoxic ischemic encephalopathy. That's an important area for the pediatricians or neonatologists. But I think to understand temporal lobe epilepsy, one has to know about that. That's the reason I put this also. So HIE and the structural causes, infection, genetic, metabolic, unknown, like in the adults, and comorbidities also. They have put that. So this is the neonatal seizure types. Right. Now look at the new and old classification. Old, we all are familiar with that. I'm sure almost all are familiar with that. New thing, I think most people are not familiar. So better to get familiarized at least this from this lecture. The reason is, in the future, when you're practicing or when you're reading journals and other things, you are going to come across this, the new classification, particularly for the trainees. Old one, you know, onset and location, partial, generalized. We are familiar. The current categories, instead of partial, they have put again focal, and generalized again generalized. And they inserted this unknown category also. Then level of awareness. In simple partial, you know, the awareness is not lost, right? Complex partial, it is impaired, right? So the new category, simple aware seizures, and complex impaired awareness seizures. And then secondary generalization has been, you know, now they call it focal to bilateral tonic-clonic. Focal to bilateral tonic-clonic කියලා තමයි දැන් කියන්නේ ඒකට. Right? And disorder තමයි කලින් කියපු නම. Now we call it disease. පොඩි වෙනස්කම්, but this is interesting. Now partial, see now, complex partial. Now we call it complex impaired awareness seizures. Simple partial seizures. Now we call simple කියන්නේ නැතු දැන් aware කියන්නේ මෙමය. I just want to say simple කියන්නේ දැන් ඒකට focal aware seizures. We use the term focal instead of partial, and complex කියන්නේ we call it focal impaired awareness seizures. So look at the new thing. Now we'll get to the epidemiology of epilepsy. In the world, in the developed nations, it's about 3 to 9 per 1,000 population. That's a lifetime figure. And then Afro-Caribbean countries and Latin America is very high, 49 to 57 per 1,000, probably because of the poor neonatal care and antenatal care. And India and Pakistan also somewhat similar to the Western figures, 2.2 to 9.9 per thousand. And Sri Lanka in lifetime prevalence, 9.02 per thousand. They have done the research in Kandy by Professor Sena Nayaka, and that is again similar to the Western figures. Differential diagnosis, the usual stuff. I'm sure you all are familiar with syncopal attacks, migraine, cardiac problems, arrhythmias, metabolic causes, substance withdrawal, particularly alcohol withdrawal, and other psychiatric disorders like anxiety, dissociative due to seizures. Sleep disorders sometimes can mimic epilepsy, transient global amnesia, vertigo due to various things in the ear, and other causes. Transient ischemic attacks, those are some of the things, common things I put for differential diagnosis to understand that etiology of epilepsy. Etiology. Basically, you get this genetic, metabolic, structural lesions, degenerative, vascular malformations, trauma, infection, substance, usual stuff again for the trainees. I have put that. But genetic etiology is very interesting nowadays. A lot of things happen in this genetic and metabolic causes. You will come across these terms also when you read all textbooks: idiopathic, symptomatic, and cryptogenic. Idiopathic means you can't find the reason for epilepsy. Symptomatic means there is a definitive reason, like a brain tumor or hematoma, infection or something, cytomegalovirus or something. You can find the reason. Cryptogenic means that the clinician will know there is a reason but can't find at the moment. That's called cryptogenic. So there, these terms are also there in the literature when you're reading. This is a picture of tonic-clonic epilepsy of a child, tonic phase and the clonic movements. This is again adult with tonic, clonic, and postictal stages of epilepsy. I have put that just to distract you all. And tonic phase in the generalized tonic-clonic seizure, you get this epileptic cry, and then cyanosis and generalized stiffening of body and limbs, generally extended like back arch, and incontinence. And then chronic phase, eye blinking, cyanosis, frothing of saliva, and chronic jerks of limbs and body and head, right? Chronic. And then post-ictal confusion or fatigue, where you get limbs are generally, flaccid and paralyzed like, right? All right. This is a picture of generalized spike wave pattern, generalized epilepsy spike wave pattern, right? It's very clear, spikes and waves. And this is, again, a picture of absences. Absences are also generalized. Remember that it comes under generalized epilepsy. Characteristic 3 hertz per second, right? This is a characteristic thing for the trainees, right? I'm sure that you're familiar with this EEG record. Now we'll talk about epileptic auras. What are the auras? Auras are found in focal seizures, or else these focal seizures are again called localization related seizures. If you read textbooks, you will come across that term more often, localization related seizures or focal seizures. But remember, about 10 to 20% of patients with even focal seizures, they don't experience auras. So again, focal seizures are simple partial, very familiar. And you can come across motor sensory phenomena depending on the site of the irritation, initial irritation, and then complex partial seizures. Motor sensory phenomena, again, depending on the site of the irritation, you can get that. Right? This EEG of patient with temporal lobe or complex partial seizures, left temporal spikes are there. Arrow indicates. There is arrow, and then you can see that spikes of temporal lobe. Now we'll talk about psychiatric disorders in epilepsy. Psychiatric comorbidity is very high in epilepsy, right? If you read textbooks, particularly Ishman, you get so much of research work. They have referred to that research work, and from study to study, things are different. But I have put a general thing. about 20 to 40% of the patients with epilepsy, they do have some form of psychiatric morbidity. So it's very high. So psychiatrists should be aware of this. About almost the half, they do have psychiatric problems, epileptic patients. This is the classification put forward by Fenton, Professor Fenton. He was one of our external examiners in good old days. Unfortunately, he is no longer there. He's dead now. But he has done so much of work with regard to epilepsy. And his classification, we are still using, or we are familiar with that classification still. Disorders due to the brain disease causing fits is one. Right? Disorders due to the brain disease causing fits is one category. And disorders time linked to the occurrence of seizures is another category. And under that, you get this pre-ictal or prodromal symptoms and ictal symptoms, auras and automatisms, particularly in complex partial seizures. And then there's a thing called absence status or complex partial status or status epilepticus. That is also a ictal phenomena according to Fenton, and post-ictal automatisms. Right? Even during the late period of ictus, you get the automatism. Post-ictal also you can get automatism. But particularly you get auras in ictus. Automatism in the late part, you get that. And post-ictal automatism or confusional states or clouded states are there. Now it's called delirium, post-ictal delirium. Or then there's another category called post-ictal psychosis. And then there are interictal disorders like, in between epileptic attacks, schizophrenia-like psychosis. Right? Interictal, I'll come to that later. And according to Fenton, the third category is disorders unrelated in the time to the seizure occurrence. Right? Disorder unrelated. Right? Under that, he described disorders of childhood and adolescence, neurosis, and then personality or conduct problems, antisocial or mixed problems, so many, and childhood psychosis, they included in that category. And disorders of adult life, personality disorders, personality change, and some neurosis, behavioral disorders, sexual dysfunction, which is a common problem in epileptics. And then I think ictal one has been included here. And post-ictal things, psychosis, affective, schizoaffective disorders, chronic schizophrenia-like psychosis, and dementia by Fenton. Right. We'll talk about these things one by one, to some extent if we have time. And then another person called Pon, he also put these things in 1957, few decades ago. That is another important, he's another important person with regard to this. Same symptoms, symptoms directly related to the clinical epileptic attack, pre-ictal phenomena, ictal, post-ictal manifestations, and then personal disorders, psychosis, and so on. What are the ictal symptoms? Ictal symptoms, and you must get familiarized yourself with what are the ictal symptoms. Usually they are brief and transient. Brief and transient. Anxiety symptoms are common. Up to 1/3 of the patients with focal seizures, they develop anxiety symptoms during the aura. They get severe anxiety sometimes, right? Like panic attacks sometimes. And then depersonalization, derealization, they are there. Depression less than anxiety in ictal period. Psychotic symptoms are also there. Hallucination, the visual, olfactory, auditory, gustatory, mainly associated with partial seizures, mainly. And aggression is very rare. Remember that. Aggression, even though we are talking about epilepsy and aggression is very rare during the ictal period. Mostly unintentional and undirected violence can be there if you are trying to hold them or if you are trying to obstruct them. They assault persons without realizing what they are doing. What are the ictal symptoms? In complex partial seizures, the commonest thing, another commonest ictal symptom is epigastric aura. You all are familiar. Unusual sensations coming from the epigastric area towards the throat. And then there's the called cephalic aura, headaches, basically. You get headaches. and anxiety and fear. And I have already discussed about these auditory and visual hallucinations and illusions of familiarity, unfamiliarity, or deja vu, or Jameson phenomena, and dream-like states are also there. Some people they are in a dream-like state, panoramic views, panoramic states, and forced thinking. Some people they get, forced thinking means they get thoughts forcibly into the mind about the past things happen. Sometimes very distressing. Some people they can remember some things. Some people they can't remember all those things. Then automatism, we'll describe that later, particularly in the latter part of the ictus. Soon afterwards, they get the automatisms. And if you look at these ictal symptoms, the majority, the focus in the limbic and temporal lobe, right? Limbic area and the temporal lobe is the focus in the majority of the patients. But sometimes, remember, frontal cingulate cortex also, maybe they have lesions in the frontal, 1/3 of the patients, frontal cingulate, or else even in the parietal lobe sometimes, when it's close to the temporal lobe, they experience the symptoms. Automatism, this is the interesting thing, right? And the trained should know about the automatism. We should know about this. Seizure discharge must spread to the midline upper brain structure and the contralateral areas of the opposite hemisphere. So the seizure discharge should spread from the midline upper brain structure and contralateral areas of the opposite hemisphere with clouding of consciousness. They have the clouding of consciousness also, or impairment of the level of consciousness, which occurs commonly in T.L.A, temporal lobe epilepsy, occasionally in frontal lobe, parietal lobe lesions. Lesions of the mesial surface of the either hemisphere, frontal lobe, parietal lobes, or temporal lobe. They think called ictal automatism. Particularly during the ictus, they get the automatism, or soon afterwards. I mentioned that. I think latter part of the ictus, or soon afterwards, they get the automatism. So it's called ictal automatism when it is happening in the ictus. Remember, sometimes in generalized or absent status also, generalized seizures, that's even in tonic-clonic seizures, or in absences or absence status, you can get sometimes automatism. But commonly, you get that in focal epilepsies, particularly in the temporal lobe. Initially, with intense electrical discharge of the brain, patient develop stereotype behavior, and then subsequently complex behavioral patterns. So initially stereotype behavior, and then complex behavioral patterns with clouding of consciousness. That is due to the inhibition of neurons following intense ictal activity. So the intense activity period, you get the stereotype behavior. This is important, and then subsequently complex behavior with inhibition of neurons. Most of the time is brief, 5 minutes or less, about 80%. Again, in automatism, well-structured, goal-directed behavior is very unlikely. So, because of fear, or because of the clouding of level of consciousness, or when the other people are trying to hold them, they may become violent, right? And may assault the people. But, intention of assaulting, like normal people may not be there, right? That's the important thing to remember. Intention, when it comes to intention. Examples of automatism, if you read books like Lishman, there are so many categories. But I think I have put some of the common things like oro-alimentary automatism. You all are familiar, isn't it? Lip smacking, licking, chewing, swallowing, tooth grinding. Those are some of the common things, right? And the trainer should know when you come across a patient with lip smacking, licking, chewing, that's the oro-alimentary automatism. And mimetic, the word used to describe facial expression suggestive of an emotional state of fear. And gestural, you know that various gestures, and manual or pedal, fumbling, tapping movements, hyperkinetic, pelvic thrusting, pedaling, sometimes like sexual performance, pelvic thrusting, hyperkinetic, verbal grunts, like repetitive utterances of words and sometimes sentences, and gelastic, there's sudden uncontrollable laughter. Then there's a category of dysphasic, impairment of comprehension with paraphasic errors. These are some of the common things, but there are other categories if you read. I think you may get familiar with some of these common things. Now, when it comes to crime of violence and epilepsy, automatic behavior is a very rare explanation, right? Automatic behavior. Now, that's the important thing. And the crime is no more than in general population, right? No more. But there is an over-representation of in prisons due to other reasons. With these people are imprisoned due to petty crimes, due to various social problems, they were imprisoned. So there was a belief, even Maudsley, Maudsley Hospital, London, the famous hospital, Professor Maudsley, good old days, felt epilepsy is very violent, right? Sadly, those days the people felt like that, but nowadays things have changed, right? And generally, no more than the normal people in the public. Automatism, I think this is forensic part, but I think in the UK legal system, there is a thing called sane automatism and insane automatism. Sane automatism is due to, according to again Leishman, if you read that, due to extrinsic causes like acute head injury can give rise to sane automatism. Insane automatism due to intrinsic causes like epilepsy. I think I'll stop with that with regard to legal implications in epilepsy. You can read further, actus rea and mens rea and so on. Then that's about the ictus. Then periictal. Periictal means around the ictus. Preictal, prodroma, all know about that. A few hours to few days period is before she says called preictal or prodromal period. You normally get anxiety symptoms, irritability, lability of mood and depression. And sometimes they are a bit aggressive. And these symptoms are relieved by the sheath. And then there's a thing called postictal confusion or postictal delirium. Generally a brief period, common again after complex partial or chronic sheaths. Both can give rise to this postictal confusion. And there's impairment of awareness and consciousness. And usually there's an amnesic period for the episode. EG shows diffuse slowing. And depression, mild to severe, sometimes during the post-ictal period. Sometimes they can have suicidal behavior. Can last up to 2 weeks, roughly. But generally it's a brief period, generally. Now, this lateralization, more common is right-sided temporal lobe or frontal foci, according to K.A.L.A. And anxiety is less common in the post-ictal period. Mania is very rare, extremely rare. Now, psychosis in epilepsy. I don't know, I'm confusing you all, but I think you must know about all those things. Post-ictal psychosis is the commonest form, post-ictal. Most commonly observed psychotic phenomena in epilepsy. And mostly associated with temporal lobe epilepsy. Look at the percentage. 25% of epileptic psychosis were categorized under post-ictal psychosis, and the prevalence is around 6%. What is the definition, or what is that really? I put the Leishman's one. I think that's better. Post-ictal psychosis occurs lasting up to 24 hours of lucid period after the seizure. Mixed pleomorphic picture with paranoid grandiose and religious delusions. So it's a mixed picture with all sort of delusions and sometimes hallucinations. And there is a prominent variable effect also, right? And so you need to understand that the other definition, episodes of confusion or psychosis immediately following a seizure or developing within a week of return to apparently normal mental function, maybe having a brief period of lucidity, 12 to 24 hours. That is also somewhat similar, really, right? Those are the definitions given by the people for post-ictal psychosis. But you must remember at least one. Usually this is a transient phenomena, but can last up to 2 to several weeks. According to Leishman's chapter is few hours to 18 days. But anyway, remember, 2 weeks to several weeks, but maybe few hours. They do have clouding of consciousness and delusions and hallucinations, or without clouding of consciousness, they have delusions and hallucinations. So the picture may be somewhat mixed. And you should not have other causes like drug toxicity or anti-epileptic toxicity to cause the psychotic phenomena. Post-ictal psychosis also occur in more in bilateral foci, particularly in temporal lobe epilepsy. Look at that, bilateral limbic lesions like encephalitis, head injury, similar things, trauma to the head, vascular sometimes, but mostly encephalitis can give rise to T.A.L.A or focal epilepsy, and then more post-ictal phenomena, psychotic phenomena. And there are variable theories, suggest a theory like dopamine hypersensitivity or GABA-related mechanisms were postulated. Normally, we give benzodiazepines if the patient is disturbed. Antipsychotics are usually not recommended or indicated unless they develop chronic symptoms or recurrent symptoms with more frequencies. When they have more frequencies, they develop chronicity and recurrences. Then even interictal psychosis, then one can think about giving antipsychotics. Otherwise, for post-ictal psychosis, antipsychotics are not recommended because it resolves spontaneously. The main goal of management is seizure control. Right? Seizure control is the main goal of management. And benzodiazepines can be given. Sometimes the patient is extremely disturbed and then one has to use antipsychotics with care, maybe to control the aggressive behavior. Otherwise, no need, because they resolve spontaneously. Now, this is another interesting area, interictal psychosis. Now we are talking about post-ictal, now interictal. Again, if you read the literature, the prevalence is very variable. But anyway, 3 to 7% tune. I think that's a reasonable thing. More in T.A.L.A, up to 17%, and 2% in other focal epilepsies. Now remember, the duration is about 10 to 15 years preceding epilepsy. So they have epilepsy, and then after about 10 to 15 years, they develop this interictal psychosis. And mean duration of preceding epilepsy is about 14 years. So after a long period of time, they develop this interictal psychosis. This is a picture of a psychotic patient, I think old picture with epilepsy. Now, phenomenology of interictal psychosis, they do have first-rank symptoms predominantly. Schizophrenia-like psychotic states with paranoid delusions, paranoid ideas, and auditory hallucinations, thought disorder, etc. Right? Frequently, they have first-rank symptoms. Now, according to Slater, who was a famous neurologist, was in, I think, he was in the UK, and then he observed these people and found their personality is relatively intact, not deteriorated, and they are more friendlier than our traditional or usually schizophrenic patients. So they are somewhat different. Now, this Flo Henry's laterality theory has been debated, and now it is regarded as a very controversial thing. Left-right focus and schizophreniform psychosis, left temporal focus, and schizophreniform psychosis is substantiated by some studies, whereas right temporal focus and effect has not been substantiated. So this lateralization is another problem. It's a controversial thing. If you read studies, from one study to another is different. Now, depression. I think I'll talk about depression a little bit more. I think I will have to take few more minutes after the 1 hour, I think. But anyway, depression related to epilepsy. This is a very important area. Now, prevalence. In the community studies, they found 22%. And in outpatient clinics, epilepsy clinics, it's about 55%. And if somebody has recurrent seizure, it's about 20 to 55%. So fairly high number, maybe more than half even. And if somebody has intractable epilepsy, it's more than 40 to 60%. It's more. It's about 40 to 60%. So intractable epilepsy, or when the epilepsy is not properly controlled, the depression is more, right? More than 50% of the patients, they get this epilepsy. Depression. Suicide rates. Before that, I'll talk about depression is more common in epilepsy than in other chronic medical conditions like insulin-dependent diabetes mellitus and CVAs, as well as bronchial asthma. They have compared depression in epileptics and other disorders, other physical conditions, and found depression is more. And suicide rates 5 times greater than the general population, more with TLE again. And there is an increased rate of attempted suicide also, 25%. So it's a major problem. Depression is a major problem in epileptics. Depression, more in complex partial seizures and more amongst patients with late onset seizures. And they have mentioned this failure of partial seizures to undergo secondary generalization. I think you can ignore that. And current research has shown there is no association with lateralization, or is doubted by various studies. Lateralization is the site of the lesion of the brain. Intractable depression, intractable, commonest. And many studies show 17 to 25%. And some studies, figure is very high. And there is a two-directional or bidirectional way in depression and epilepsy. If you look at the symptoms of depression in epileptics, epilepsy can give rise to depression more in epileptics, and when they are depressed, they get more seizures. So it's bidirectional thing. Anxiety is also the same. Look at the symptoms of depression. Now we are talking about the depressive disorder or the depressive episode or depressive illness. Symptoms of depression in epileptics is about 4 to 37%, highly variable depending on the study. You can think about maybe about 20% if you look at the average. But anyway, it's high. Depressive symptoms are also high. Depression is also high compared to the general population, very high. Treatment of depression in epilepsy. One has to optimize the seizure control. One has to. So one of the main areas to control the seizures and reduce polytherapy as much as possible, because sometimes even anti-epileptics can give rise to depression, and we are going to talk about that later. And they have recommended mood stabilizing anti-epileptics like lamotrigine, carbamazepine, and sometimes we'll have to give antidepressants depending on the severity of depression. And the mainly we recommend SSRIs, for instance, sertraline, citalopram, or any other SSRI. ECTs are not contraindicated. In treating severe intractable or resistant depression, ECT, in fact, it can raise the epileptic threshold. So it's beneficial to control the epilepsy as well. So depression again, because this is so important, so I'm highlighting again and again. Commonest intellectual disorder, remember that. It's common than psychotic illnesses. Depression is the commonest. Atypical presentations and chronic dysthymia are more often seen. Atypical, like burning sensation, somatic symptoms, or irritability, right? And dysthymia are more often seen than typical, diffuse symptoms. So there is a high chance of missing. And causation, why it is happening? There are so many theories. And here also you can apply the biopsychosocial model of, you often use that to describe many things in psychiatry. You can apply that also. In Sri Lanka also, I think our Silumini has done a study with our help. She is the main figure in this study, Silumini De Silva. Now she's a consultant. She did a study in Ragama and found the prevalence of depressive disorder was about 22%. This is similar to the Western figures, and this is high, and the risk is higher during the early phase of the illness. So one has to find out, one has to follow these people, and particularly in the early phase, is higher. And she also found some of the anti-epileptics can give rise to depression, but I haven't put that because of time constraints. But you can refer to Silumini and find out what happened. And this picture of, cannabis sativa. I have put that because good old days, the people, they use cannabis derivatives to treat epilepsy. Even nowadays, if you look at the US, now they have recommended chemicals from cannabis sativa to treat epileptics. It's interesting. Right. What are the other intellectual disorders? Anxiety disorders are very common. It is almost the same according to Lishman, but some researchers, they found a bit lower, but higher than the general people without epilepsy. So anxiety disorder, what are the common things? Generalized anxiety disorder is common. Panic disorder, agoraphobia, social phobia, those are common. And then there is a thing called schizophobia. Some people, they are frightened of having another schizo. So they avoid social situations. They avoid working, and they become housebound sometimes. Right? So you need to understand that anxiety disorders are also common in epileptics. Again, with more in temporal lobe epilepsy. Right? Okay. Bipolar disorder is very rare. Less than 5% or less than even 1% according to this study. This is a picture of epileptic carried by the people in good old days. And we'll talk about now about what is personality change. This is a controversial thing. Role of the brain damage. When there's epilepsy, there's a brain damage also, isn't it? Which can give rise to the seizures as well as the personality change. Seizures themselves or drugs used in epilepsy can cause problems. And stigma, psychosocial factors obviously can contribute to personality change. Right? And then Geschwin, this name you will come across on and off. He explained a syndrome. That's called Geschwin syndrome, hyperphagia. They have hyperphagia. Sorry, hypergraphia, excessive compulsive writing, hypergraphia, and religiosity. And they become over-religious, philosophical, maybe pedantic, and the speech is circumstantial, sticky, obsessional, hyposexual tendency, and viscosity, difficult change. Change means that when they start a conversation, they keep on talking about things like that. So that personality, it's a controversial thing, but anyway, still, people, they talk about that. Associated with TLE mainly. Associated with TLE. Right. Now we'll talk about bits about this role of limbic system in epilepsy. Force in the limbic system may lead to complex partial or focal seizures. Right? And Adamek, he described vividly about this role of limbic structures in provoking psychic phenomena. You know the psychic phenomena, we're talking about them. They think called limbic aura, or formed images, buzzing, humming, and irritability. Right? So limbic aura, limbic structures are involved. They get these things associated with intellectual psychopathology, like we were talking about them. Right? This picture of the limbic system, you are very familiar with that, I'm sure. Amygdala, hypothalamus, this area, hippocampus, and then Papet circuit, the entire thing, right? Limbic. I just want to put few things about temporal lobe epilepsy also, little more, because this is important to psychiatrists. There is a thing called mesial temporal area and mesial temporal sclerosis or Amundsen sclerosis. You know, in the temporal lobe, which is the most vulnerable area in the temporal lobe for hypoxia. That's the very reason I put initially about hypoxic ischemic encephalopathy in neonates, which can give rise to temporal lobe sclerosis subsequently. Right? Good old days, the people felt birth trauma or which was giving rise to this lesion. But nowadays, the people think about the hypoxia and febrile convulsions more often about when you are describing this mesial temporal sclerosis. Sometimes you can have unilateral hippocampal damage, or sometimes you can have bilateral, particularly due to infections and trauma. And this is a picture of temporal lobe epilepsy, right? The right side, there is atrophy of the temporal lobe, whereas the left side, the normal temporal lobe. White arrows indicate the atrophy of the temporal lobe. White arrows. Right side atrophy, the left side normal. Other areas of interest, there is a thing called forced normalization or alternative psychosis of epilepsy. This is for the trainees. Landolt initially described this inverse relationship with seizure control and the occurrence of psychosis, where you get the normal EEG and suppression of seizures. And then alternative psychosis, that theory also put forward by people. When there is no seizure, you get psychosis. When there are seizures, no psychosis. Right? And Krishnamurti, another person, recently put forward other theories to explain various things like coma with psychotic symptoms. He described these ion channel disorders and then neurotransmitter hypothesis. I think they are pretty new things. I think we were talking about this interest, more recent interest about anti-epileptics and depression. I think I discussed that. Then we'll get to this neurocognitive problems in epilepsy. There's another area of cognitive. When there's a brain damage, you get neurocognitive problems due to the underlying brain damage, as well as type of the lesion, site of the lesion can give us things, factors related to the seizure, and factors related to the treatment. All those things can give rise to neurocognitive problems. And when there are more seizures, more problems. When temporal lobe epilepsy, focal seizures, more. And when you use anti-epileptics, polytherapy, more problems. Vitamin deficiency with anti-epileptics, more problems. So one has to identify this. When there's a neurocognitive problem, there are, when you're using rehabilitation processes, you need to be aware of this. And suggested treatment things for vagal nerve stimulation, conjunctive replacement, antidepressant sometimes, stimulants, memory, there's a thing called memory rehabilitation, behavioral approaches, and treat the comorbid psychiatric problems and correct the deficiency states and avoid polypharmacy as much as possible. All right, this is the usual stuff again. Frequent fits, give rise to trauma, brain restricted activities, anxiety, loss of interest, loss of control, learned helplessness, discrimination, stigma. Okkoma enna puluwan with frequent fits and can give us diffuse brain damage, low IQ, poor impulse control, all those. And focal temporal lobe epilepsy, more problems. Clinical and subclinical, sometimes impaired information processing is there with epileptics, which can give rise to problems. Obviously, social education problems and medication, right? Cognitive impairment, reduced impulse control, sex hormone and low folate levels, dysphoria, medication also, right? Other important related areas, I think you can think about autism, mental retardation, intellectual disability, and Isle of Wight studies for trainees. Now, I just want to talk about this reflex epilepsy also a little bit, because that's another important area. With a bizarre presentation, can mimic psychiatric disorders. What is a reflex epilepsy? It's a seizure, right? Seizures are induced by either external or internal stimuli. Examples are photic music, startle, sexual activity or micturition, hot water, eating, reading, mental arithmetic. Eating epilepsy is the commonest in candy. Professor he has done studies and found eating epilepsy is the commonest in candy. And Ragama also, we have discussed so many cases, but this is an interesting case report. So I just read that. Even spending few more minutes, a 16-year-old schoolgirl became intermittently fearful and anxious with depressed mood for about 2 to 3 months. These episodes lasted for about 5 to 10 minutes. These spells were mostly encountered whilst at school during reading sessions. She developed muddled thinking and became disoriented for some time afterwards and then recovered. She has changed the school about 4 months ago from Canada to Colombo, and initially it has been thought her symptoms were related to adjustment difficulties by the teachers and doctors. And in fact, she was offered counseling sessions. And then with intense fear, she came to see us, and we noticed this change. And EEG revealed left temporal spikes and waves, and the MRI brain showed a cystic lesion in the left temporal lobe. And she has been referred for neurosurgery, and they want to follow up before doing the surgery. That's interesting. Many people they miss that because this is very complex. But the patient has been changed. She has changed the school, and she developed the symptoms whilst reading at school. So that's a reflex epilepsy example. Missed one. So many cases reported from Ragama also, frontal lobe seizures and reflex epilepsies. And bits about psychogenic non-epileptic seizures a little bit. Prevalence is up to 30% of intractable epilepsy referred to specialist clinics, about 30%, and 10 to 20% new presentations to epileptic clinics are having pseudo means psychogenic non-epileptic or dissociative seizures, and 20 to 26% misdiagnosed, right? And there are so many names to describe these people. Dissociative, and some about 10% they do have concurrent seizures also. So be careful about this. This is often missed and mismanaged, and most of the patients are not properly treated. In fact, they have shown bit high prevalence rates amongst intellectually disabled people also, and psychotherapeutic intervention and psychosocial support is the mainstay of treatment. This is a picture of pseudosis anyway. Now look at this video clip. I think this is interesting. With this patient also, she has been referred by exocystomy after seen by psychiatrists as well as um, so many people, and thought it was psychogenic. I think you can observe this particular patient. Look at that now. What do you think about that? Now, other side of the hand, other side. All right. So what do you think about this one? What do you think about? It has been diagnosed as depression by people, some people, it's interesting, or dissociation. But somebody has referred this patient, I think ritualistic healer, because she has gone for native treatment after no improvement with psychotherapies and other things. So it's interesting to note that initially you can see the movements of the right side, right side, and which was rhythmic and bit unusual, and then it spreads to the other side, right, with movements again. This is a rare, this is not a rare thing. This missed often, and this is the age of the patient. It shows left frontal lobe focus, right? Left frontal lobe epilepsy, and the MRI showed a meningioma, and in fact, she has been referred to the neurologist, neurosurgeons for surgery. It's interesting. It has been missed for some time. So I think when you come across these unusual presentations, you need to investigate and you need to assess them properly. That's one thing to remember. So this is a frontal lobe seizure, right? So one has to be familiar with the present is very haphazard. Particularly you get these movements, haphazard movements, particularly at night, kicking movements, right? Sometimes punching movements. And the patient is not that aware. Sometimes the patient is aware. Because these are simple partial or focal seizures. Patients sometimes they wake up. Sometimes they aware, but the other people in the bed, they are the people they notice that, right? So you have to ask them to video these things, right? So there is thing called frontal lobe seizure, nocturnal frontal lobe epilepsy, or seizures, more common during sleep, right? There, I have put that, and torch paralysis. You need to understand what it is. Following simple partial seizures, status epilepticus. When there is no when they have repetitive seizures without recovering for at least more than 30 minutes. And then there's a thing called SUDEP. People are talking about that. Sudden, unexpected death of epileptics among epileptics. And driving and epilepsy also, you need to get familiarized yourself. Driving and epilepsy. With for commercial things, the duration is different. For our light vehicles, the duration is different. According to UK things, again, Lishman, if you read Lishman, you come across that also. They have included that. Or Royal College of Psychiatrists guidelines are there. At least 1 year period should be seizure-free for light vehicle or for heavy vehicles. So, passenger transport vehicles, 10 years seizure-free period is required. So it's important, right? The new therapies, just before finishing, the new directions. Vagus nerve stimulation by an implant, which is currently under research work, and transcranial magnetic stimulation, you are familiar, and epilepsy surgery, again, you are familiar, mainly for TLE. They do that widely. Even in Sri Lanka, I think people, they try to do that. They do sometimes. And lot of new medication, lot of therapies. And then there's interesting thing called mammalian target of rapamycin, MTOR inhibitors. They do research on that also. So some of the new therapies, a lot of genetic studies are done, and imaging techniques are also getting more and more advanced. So I think in the future, you might be able to do more work with regard to epilepsy. And this is the end, really. I have just put this foundation, this Colosseum foundation, and good for psychiatry trainees. If you have good foundation in psychiatry, your building will be there. At least the base will be there, right? So it's important to know put the foundation in psychiatry. In real psychiatry, pathology, and that's the base. Whereas in medicine, that's the pathology. According to our good old days professors of pathology, they highlighted that really. And for medicine, psychiatry also, if you have the base proper base, I think the building will be there. Otherwise, the roof and the windows and other things won't be there unless there is a proper base. So the trainee should know the basic stuff. I think that's all about the lecture. I don't need to summarize that, but I think most things are highlighted to some extent, right? Okay. If there are problems, you can ask you. I try to answer if there are problems.
Thank you very much, sir. That was a very clear and a very comprehensive presentation. I am sure there will be a lot of questions by the trainees as well as the psychiatrists. Any questions to Professor Kuruppuarachchi?
This Ajit.
Yeah, Ajit, can Ajit? Yeah.
Yeah, I'm just wondering now with the ECT and the epilepsy, in a sense that ECT also provoke epileptic or not epileptic seizure, and then it improves the psychiatric illnesses. And then what is the newest concept about that?
Yeah, in fact, this is a very old theory, Ajit, antagonistic theory. When the people, they did have epilepsy, epilepsy, the psychotic symptoms disappeared. That was one of the reasons to describe this ECT and epilepsy, ECT, the mechanism. But things, currently, the seizure threshold is increased, and they change the same, the treatment pattern is the same in epileptics as well as the normal people. The mechanism is still the same. So the treatment is still the same. But when it comes to the neurochemical basis of epilepsy and depression, the same things are happening, right? So the treatment outcome is the same. But whereas in ECTs, you modulate the neurotransmitters as well as there are up and down regulations of the transmitter systems in the brain, and there's a change eventually. But linking ECT to epilepsy has not been widely discussed, right? But therapeutic is used. That's the answer I can give. Therapeutic is used, and antagonistic theory has been put forward by many people in the past. I think I don't know whether I have answered the question, but this area hasn't been widely discussed. The neurochemical basis of ECTs and epilepsy has not been discussed. Maybe there, but I haven't read that to that extent. I think better read that and see what is happening. I need to read that also, whether there are new things.
Thank you, sir.
Right? I'll also read and see.
So this Gihan, this may sound as a very silly question, but it's a very important clinical question that most of the trainees ask for examination purposes for the exams. Now you very clearly mentioned about the prevalence of depression in epilepsy and the magnitude of the problem. Now, when you have in a patient depression coming after epilepsy, are the trainees at the exam supposed to say it's organic mood disorder or epilepsy with comorbid depressive disorder?
I think this is a tricky area. According to the literature, if you read Lishman, or if you follow the organic psychiatrist, they talk about epilepsy with intellectual depression, epilepsy comorbid depression, right? That's the things given. Even the 2017 International League Against Epilepsy, they discuss in that way. But we all, as psychiatrists, we all are familiar with organic mood disorder. And we put the trainees, they talk about this organic mood disorder. We don't normally penalize them. We just accept that, isn't it? Even when the people, they talk about that, we accept that. That's the general, our trend or our training. But if you look at the real thing, ideally, if you read the real organic textbooks and the new literature, they talk about, particularly the people they are talking about epilepsy, they include epilepsy syndrome or epilepsy, the type of epilepsy, and then the comorbidity. Interictal, so epilepsy is there, interictal comorbid depression. Or immediately after seizure, then is postictal, or else pre. But for the exam, we don't give that. We give generally interictal disorders, this thing, interictal disorder, right? Ideally, it should be interictal.
So it's better for the trainees to mention it's epilepsy with interictal depressive disorder.
I think that's the ideal. That's the proper way.
Rather than organic mood disorder.
Rather than organic. Organic means now the patient is having epilepsy, and now patient has epilepsy with, because the damage caused an organic thing. Because this is reversible if you treat that. Interictal depression is reversed. Sometimes not reversed, but most of the time you can treat that. This thing.
And so that applies for the interictal psychosis as well, isn't it? So
that's right. Yes. So prognosis is better.
Rather than epilepsy and comorbid schizophrenia, it's better to say epilepsy with interictal psychosis.
Oh, interictal psychosis, schizophrenia-like.
Yeah, interictal psychosis, schizophrenia-like.
Is my ideal with it. And
thank you, sir.
Thanks, Gyan. Sorry, Gyan. I don't know. I clarified most of things as much as possible, but this is a difficult topic and people are not that interested, but it's an important topic rather than this other topics. Really, other topics are also important, but this is a different topic, isn't it?
And this is a topic that most of us find difficulty in, especially when it comes to exams, and the trainees are also a bit confused about the terminology, how to phrase the most comprehensive diagnosis in according to the ICD-10. So I think you cleared the confusion very well, sir. Thank you.
All right. Are there any other questions? If not, are there any? Unlike listen it. Make a than a train is letter.
No, I'm sure it was very clear.
At least that alut classification 2017. That's a very important thing.
The simple and the complex, the with awareness and with impaired awareness. That was very clear. Yes.
Oh, etiology comorbidity, comprehensive. There are a lot of new things happening in the world. So I try to put some of things. Hopefully, 10% for the training, it's okay.
I'm sure it must be much more than that.
All right.
Any more questions to Professor Kuruppuarachchi? Trainees who are sitting for the exam this time probably will have a few questions. You may be seeing there's quite a lot of comments and acknowledgements thanking you for the.
All right.
I'm sure they benefited a lot. Right. Shall we then call it a day? Yeah.
Okay.
So thank you very much, sir. Again, now you may have seen there were more than 90 participants participating in your lecture. So there were quite a lot of very senior psychiatrists like Dr. Damini Jayasinghe, Dr. Shyama Arambepola, Dr. Sivayogan, Dr. Garamanadan, Professor Shehan Williams, Dr. Swarna Vijayatunga, Ajit Jayasekara, Dr. Tulshika Vas, and so many others who, and a lot of trainees who attended this online lecture. So I think it was very clear to all of us, and you being one of the most today and a senior professor in psychiatry, thank you very much, sir, for taking your time and giving us this opportunity, not only for the trainees, for us as well, to clear the confusion between the diagnostic dilemmas. And then you gave us a very clear contrasting from the old classification to the new classification in diagnostic terms for epilepsy as well as psychiatric manifestations. And all the others will agree with me that it's a very important and a confusing topic that we have, especially when it comes to classification and diagnosis. So I think you cleared the confusion for most of us, all of us, trainees as well as the psychiatrists, and you gave us the latest classification and the latest facts with regards to epilepsy and psychiatric manifestations. Thank you very much, sir. And I'm sure you will agree. I mean, you will not hesitate to give us a few more lectures in the future with regard. I mean, not only in neuropsychiatry, in other fields as well. Thank you very much, sir.
Well, thank you, Gihan, for giving me the opportunity. Thank you very much, and thank you for the college also. Thank you.
Thank you, sir.